Hello everybody, this is Carlos from Army of Nurses and welcome to another video. Today's topic will be coronary care nursing and we'll be dividing it into level 1 and level 2. We'll be covering some basic review of anatomy and physiology, and we'll also go into how to interpret a ECG rhythm and 12 leads by the end of this series. This guide is intended for new grad nurses who have got their license already, or nurses who are close to graduating, or for those who are just interested in learning more about cardiology. So let's get started. So the heart is a pump located behind the sternum, has 4 layers. The topmost layer is the epicardium, topmost. And this layer houses the coronary arteries as well. The next layer below it is the myocardium, and this is where all the action happens. So this is the pump. This is the pump that will get the blood circulating throughout the whole cardiovascular system and is going to perfuse all your vital organs. The endocardium is the innermost layer. And this layer over here is where you will find your pacemaker cells. And this is also where the attachment of the chordae tendineae will be, The pericardium, it's the cover that will wrap the heart around, and it also contains pericardial fluid. So this is going to cover the whole heart, plus has pericardial fluid. And the pericardial fluid is to lubricate the heart so that every time when it beats, the friction between the layers, it's reduced so that the heart is able to pump more efficiently. Now we're going to review some of the chambers of the heart. So the heart has 4 chambers, 2 atrium and 2 ventricles, as denoted by A, B, C, and D, as you can see. So A, this is your right atrium. B, this is the right ventricle. C is the left atrium, and D is the left ventricle. Now we're going to talk about some of the heart valves. There's 4 heart valves in your heart. There is 2 AV valves, 1 pulmonic and 1 aortic. So the main function of the valve is to prevent the backflow of blood and keep the circuit in one direction. So prevents backflow of blood plus keeps system in one direction. So that means that blood is only going to flow one way because the valve will prevent it from going back, and this way will keep the system going. It will allow the system to be more efficient, because this is the way that you can separate the oxygenated blood from the deoxygenated blood in the system. So A, this is the tricuspid valve, and B is your mitral valve. These 2 valves are AV valves because they form the barrier between the atrium and the ventricle, so they're called atrioventricular valves. When these valves close, they produce the S1 sound in your heart, and the S1 sound is the lump sound. The blue patch over here is the pulmonic valve. As you can see over here too, my drawing is not the greatest. And the red patch over here is the aortic valve, which is over here. So pulmonic, and this is the aortic. So when these 2 valves they close, they produce the S2 sound, which is denoted by the dot. Next, we're going to talk about some coronary arteries. And as a point of reference, this will be the aorta. All right, and this valve over here, if you can see from the previous slide, that's the aortic valve. So when the aortic valve closes, blood that actually backflows from the top here, they have nowhere to go because this valve, the aortic valve, prevents it from falling back into the left ventricle. So the only way for the blood to go from here, excuse me, is into the coronary arteries. So over here like this. So that's why the coronary arteries, they perfuse during diastole, when the aortic valve and the pulmonic valve, they close. Okay, so we're gonna put here coronary arteries. Perfuse during diastole. Okay. So which ones are the coronary arteries? So we have three coronary arteries. We have the right coronary artery. We're going to put RCA for right coronary artery, and this one right over here. As you can see, it comes around and it wraps to the back and inferior part of the heart. On the left side of the heart, we have the left main, which is this part over here. Left main, I'm just going to put LM. And the left main, it actually breaks off into the circumflex, this one here. And the circumflex goes to the lateral side of the heart and also goes back. The circumflex we're going to put as a CX for circumflex. And the other one is the left anterior descending, which is this one over here, right? So all the way to the front of the heart. Left anterior descending. We're going to put LAD just for reference and short forming. So the right coronary artery, which is this part over here, right? The right coronary artery supplies the right side of the heart, the inferior right side, and posterior. Okay, it perfuses the right atrium, so it supplies the right atrium, the right ventricle, the left inferior part of the ventricle, one-third of the septum, and then in 55% of people, it actually supplies the SA node, and in 90% of the people, it supplies the AV node. So 55% of the people supply the SA node, and about 90%, that'll be a good estimate, 90% supplies the AV node. And last but not least, in about 80 to 90% of people, it supplies the bundle of His. Bundle of His. Excellent. So the next one we're going to talk about is the left main, and like we said before, it branches into the left anterior descending and the circumflex, and it's this part over here. Pardon me, this like double. There it goes. That part over there, the part there that before it branches into the two arteries. So it supplies the left anterior descending plus the circumflex arteries, and when this little portion here gets blocked, it's a very dangerous heart attack that we call the widowmaker, because once this part is blocked, as you can see, you will have no perfusion to this side, neither to this side, and all this part of the heart will eventually become ischemic and die, right? So it's very deadly. So from the two, we're going to talk about now the left anterior descending, which is this part over here. Okay, this is one of the branches of the left main. It supplies the anterior part of the heart. It supplies about 2/3 of the septum. It supplies the apex. And it supplies in about 10 to 20% of people the bundle of His. Remember that from the previous slide, we said that about 80 to 90% it was supplied by the right coronary artery in 80 to 90% of people. So the next one will be the circumflex, and this is the second branch of the left main. It supplies the left atrium. It supplies the lateral, the posterior, and the inferior part of the left ventricle. Also, in about 45% of people, it supplies the SA node. And in about 10% of people, it supplies the AV node. Remember that the other portion of the people have the SA node supplied by the right coronary artery, and the 90% of the people have the right coronary artery supplying the AV node. But for the rest of the people, 45% supplied by the SA node, by the circumflex, and 10% of the people, the circumflex supplies AV node. Good. So now we're just going to talk about a little bit about blood flow, and this is mostly a review. I am going to use green just to denote the blood, the flow of the blood. So from the body, where it has been used up of all the oxygen and all the waste are coming back to the heart to going to the lung to circulate. So we have the blood coming down from the body, from both directions, from the inferior vena cava and the superior vena cava, and the blood, they mix and they go into the right atrium. On the right atrium, it passes the tricuspid valve and comes into the right ventricle. On the right ventricle, during systole, the blood will travel through the pulmonary artery and into the lungs. The lungs, they're purple because we just want to denote that that's where gas exchange happens. So the deoxygenated blood from the pulmonary artery is going to go through the lungs. Oxygen is going to diffuse in, carbon dioxide is going to diffuse out, and we have oxygenated or oxygen-rich blood coming back from the pulmonary vein into the left atrium. And the left atrium, the blood will pass through the mitral valve and come into the left ventricle. From the left ventricle, once systole happens, it will be ejected through the aorta out into the body. The body is going to use it for its metabolism to be able to sustain and maintain pH, produce energy, oxygenate the cells, removal of waste, and all the stuff is going to happen in the body until the blood returns and starts the cycle again. So now we're going to talk about a little bit about hemodynamics. And hemodynamics, all it is it talks about how well perfusion is. So hemodynamics is equal perfusion. Okay, so how well the patient is perfusing. We're going to visit this formula again, which is cardiac output denoted by CO. Cardiac output is equal to the heart rate times the stroke volume. Okay, so cardiac output is just how much blood is pumped in 1 minute. So how much blood is pumped in 1 minute, and it's usually anywhere between 4 to 8 liters. Heart rate is equal to how fast your heart is beating in 1 minute, right? So how fast the heart beats in 1 minute. And in an adult, we're gonna put it 60 to 100 beats per minute, BPM. Stroke volume is how much blood is ejected with each contraction, with each heartbeat. How much blood ejected per one contraction or one heartbeat. Okay, and this is usually anywhere between 50 milliliters to 80 milliliters, which is the same thing as cc. Okay, so now we're going to talk about the heart rate. The heart rate, like we say, was just how fast the heart was beating per minute. In an adult, usually anywhere between 60 to 100. Some of the factors that affect the heart rate is the sympathetic nervous system and the parasympathetic nervous system. This is your fight or flight. Right? It's also affected by pathology in the conduction system. This is where some of your arrhythmias can come in. It's affected by medication. Medication to slow heart rate down, namely, for example, your beta blockers. As an example. And it can also be affected by metabolic demands. Which is the supply versus demand, okay? Supply versus demand. And some of the metabolic demands will be, for example, sepsis, would be hypovolemia, low volumes, febrile, oops, sorry, not afebrile, we should put febrile instead, febrile, exercise, etc. So anything that would affect the supply and the demand of oxygen to the cells will affect the heart rate. So stroke volume is actually denoted by, it's affected by your preload, your afterload, and contractility. So it's affected by preload when I use pre, afterload, after, so that we don't write the whole word, and contractility. I'm just going to put contract. Okay, so preload is, I'm going to talk about here, preload. So preload, all it is the amount of blood in the ventricles at the end of diastole. Okay, so at the end of diastole, so once the heart is almost finishing to relax, the ventricles are actually they're already blown up in a way that they're ready to receive the most amount of blood, and that's your preload. Therefore, it's affected by your venous return. So venous return. So venous return will be how much blood is coming back from the venous circulation through the superior and inferior vena cava, and through the right atrium and right down into the right ventricle. More venous return equals greater the preload. Is affected also by the Starling's law. And what the Starling law states is that the more the ventricles are able to stretch, the harder the recoiling function is going to be. So you start thinking about almost like an elastic band. A small elastic band, once you start stretching it further and further away, you're going to see that the recoiling function is actually stronger and stronger, trying to contract and retract faster, right? So same idea with the heart. The more venous return we have, that means the more stretch the heart is going to have, and the harder the heart will be wanting to push the blood around. So that's why when people are, this is one idea, that when people are overloaded with fluid, their pressure is high, and therefore this is the whole idea why diuretics work to decrease blood pressure, right? Because diuretics make you pee the excess volume out, you don't have as much recoiling function of the heart, therefore your pressure will be lower. That's the very basic explanation of how that idea works. Right? However, we have to be careful because the stretching Stirling's law does have a limit. So what it does is, once it reaches the limit for a long and extended period of time, so people who have excessively high blood pressure over a long period of time, or they have fluid volumes that are constantly high over a chronic period of time, then they develop congestive heart failure. Which is the inability of the heart to push blood around the circulatory system effectively, right? So you start thinking about it, if you do have an elastic band that is constantly being stretched and not allowed to recoil properly, that elastic band eventually is going to adapt to the new stretchiness, and when we let go of that, the recoil function is just not going to be as strong as if when we didn't stretch the elastic band in the beginning, right? It's hard to measure directly preload, but we do so by measuring CVP, which is a central venous pressure. Central venous pressure, they usually measure in critical care environments. It can be done through central lines. Central lines, we usually attach the CVP monitor to the distal port of the central lines. It can be an internal jugular central line, or it could be a subclavian. Next, we're going to talk about afterload. And afterload, all it is the resistance in the circulatory system. I'm going to put resistance. Okay, so it can be affected by fluid volume. It can be affected by constriction, vasoconstriction, and atherosclerosis, hardening of the arteries, right? So if you start thinking about it, more fluid, that means that there is a lot of resistance because you're trying to push higher amount of fluids in an opening that is a fixed, almost like a fixed diameter, right? So when you have constriction, in the other hand, your diameter of the blood vessel where the blood needs to flow through is actually narrow. So when you have a narrower artery and you have X amount of fluids that you need to push through that, you are going to have increased resistance, right? Which means that you need to pump harder. And atherosclerosis, once the arteries start to harden, or there is some blockage or some sore, then the arteries, they lose their elasticity and they lose the ability to stretch and recoil to accommodate the extra blood. So that's why when we start aging, this is a natural process of aging, that our arteries, they become less compliant, right? So they don't stretch as much. Therefore, because they're so stiff or stiffer, our pressure goes up. We measure this by systemic vascular resistance. And systemic vascular resistance is a little bit inverted. It's an inverted relationship with cardiac output. So when systemic vascular resistance goes up, your cardiac output goes down. So, and the reason being is because if you have more resistance, you're not going to be able to put out as much, you're not going to be able to circulate as much blood as effectively throughout the whole circulatory system, right? So your systemic vascular resistance, like we said, it's actually affected by the diameter of the vessels. It's affected by the ability of the vessels to stretch. Ability of vessels to stretch. And it's also affected by how competent the valves are, so valve competence. Okay, next we're going to talk about contractility. And this is just the contraction of the muscles, right? Of the heart, contractions. So a contraction is the actual muscles, the fibers of the muscle shortening and extending, and that creates a pumping action that will circulate the blood. It's affected by both preload and afterload. And what it does is when the force of contraction, which we're going to call here FOC, force of contraction, when the force of contraction increases, either because the preload is high or the afterload is high, then it will lead us to an increased oxygen consumption. It's an upwards arrow, increase O2 consumption. That means that your heart is going to use up more oxygen in order to keep that in order to keep pushing the blood around because of all the increased preload or the increased afterload that it has. So next, what we're going to talk about is we're going to talk about some electrophysiology. And just a simple rule about electrophysiology is that electrical always follows before mechanical. So I'm going to put here rule. Electrical before mechanical. So it's just that once the heart, is ready to pump, there is electrical signals that go throughout the whole heart, and the electrical signals must be initiated always before a mechanical contraction or mechanical activity can follow, right? So some of the property of cardiac cells, I'm just going to use a different color here. Let's go pen, and sure, we'll use red maybe. Okay, so some of the properties of cardiac cells, they are automatic. So they have automaticity, they have rhythmicity, they have their own rhythm. They have excitability, they have a conductivity, they have refractoriness, and they can contract. Okay, so some of the properties of cardiac cells. So each one of these cells inside your heart, they're quite formidable because they can perform a lot of actions on their own. So cardiac cells can be automatic. They can have their own rhythm. They can become excited on their own. They can conduct electricity between each other. Refractoriness, which is the resting phase, and contractility, which is the mechanical contraction. So automaticity is the spontaneous initiation of electrical pulses. So this is initiation of electrical impulses, and this is spontaneous. Okay, so rhythmicity is just a property of the node cells to beat in a synchronized fashion. So what that means is that all these cells, the conduction of the cells, they actually trying to put it into a rhythmic contraction so that your heart beats in a constant and synchronized mode or function. So this one is node cells, and they can beat in synchrony. They can sync up. Okay, synchrony. There it goes. Excitability is just the ability of the heart cells to respond to an electrical stimulus. Respond to electrical Stimulus. Sorry, my writing is not the greatest, but that's what I'm trying to talk you through it so that things a little more clearer. Conductivity is another property of cardiac cells, and like I said, it just is a function of the cell to transmit signals from one cell to another. Transmits signals from one cell to another. Okay, refractoriness, this is the resting phase. That means that no excitability it's allowed. No excitability. And contraction is the mechanical contraction. Right? Is the actual action of pumping blood through the circulatory system. So next we're going to talk about some electrophysiology basis. So at rest, the cells are mostly positive. So when a cell's at rest, they are mostly positive. They're mostly positive outside, greater than the inside. Okay, and this is called polarized. So what happens is when depolarization starts to happen, then the polarities, that means the plus and minus, the negative and the positive charges on both sides, inside and outside the cells, they switch. And that's when the cells, they're able to, conduct and contract. So the main extracellular positive ion is sodium. So extracellular, it's sodium. Intracellular is potassium. Okay, and when an action potential is triggered, cells are becoming depolarized. Okay, so this is just a quick review. I'm just gonna write my little chart over here. And this one here is the resting membrane potential. And cells are usually in the resting membrane potential is anywhere between minus 90 millivolts. Okay, we're gonna put 0 over here. We're gonna put minus 50 millivolts over here, just as a reference. And here should be probably around 20, plus 20 millivolts. Okay, so what happens is, I'm sure a lot of you remember this little graph here. Have a spike, comes down like that, right? So we're going to put numbers onto that. So this is going to be 0, 1, 2, 3, and 4. So what's happening right here in 0? 0, what happened is sodium rushes into the cell, because remember, sodium is extracellular, is outside of the cell. So sodium rushes into the cell very fast, very, very fast. And hence you get the spike right here, right? The spike. But calcium is also rushing in at the same time with sodium. So you have two positive things rushing into the cell very, very fast. Therefore, your cell becomes less and less negative, as you can see here. It goes from minus 90 very quickly to almost like plus 20. Okay? Once it reaches step 1 right here, what happens is sodium stops moving in. So once sodium stops moving in, you can see the spike, it finishes spiking up. It doesn't spike up anymore. Okay? And then what happens is it starts to plateau down. So number 2, what happens is potassium starts to come out. So potassium starts to come out. Okay? And calcium still going in. Because remember, calcium was going in with sodium at the beginning, but it was doing it in a slower fashion. So because potassium is going out fast and sodium is still brushing in, you have this plateau almost sense, because you have a plus or minus starting to slowly balance each other. So therefore you have that little plateau that is not going down, it's not going up, right? So once we reach to number 3 over here, calcium, it stops rushing in, and potassium rushes out faster. So that's why when calcium stops rushing in, we don't have a supply of positive ions anymore, and potassium is rushing out very, very fast, right? So therefore we have a very deep drop back into the negative charges. As you can see, it's dropping down. So we go from here, dropping down all the way down, okay? It's becoming more and more negative. Once we reach number 4 over here, then we're back to the RMP, or the resting membrane potential. And once that happens, the cell is polarized again, because it's at minus 90, and is ready to begin another cycle of depolarization that we went through. All right? Next, we're going to talk about the electrical conduction in the heart. So I just wrote this just to get it ready for the guide, because it will take a little longer to redraw everything. So 8, that's where the SA node is, the signal atrial node. Also called the SA node. Okay, so it's just a little bit very close to the superior vena cava on the right atrium. B, from here, right, those are the internodal pathways. B1, I just separate that instead of going through C. This, as you can see, B1, it actually goes towards the left atrium, and this is Bachmann's bundle. C, this little notch over here, is the AV node, the atrioventricular node. The atrioventricular node, it actually causes a physiological pulse very, very slightly, which allows for blood to fill in, an atrial kick to refill the last small percentage of blood into the ventricles. D, which is this part over here, as the arrow is pointing up, that's the bundle of His. E, a little bit further down, this is the right bundle branch. F, on the other side, is the left bundle branch. And G, those are your Purkinje fibers. So how the conduction of the heart goes? So signals start on the SA node up here, right? Let me use the green nodes to the node. So it starts here, SA node. From the SA node, the signal travels down the internodal pathways and across through the Bachmann's bundle. And what it does, it causes a depolarization of both atria, left and right. Once the atria has been depolarized, the signal arrives at the atrioventricular node, at the AV node right here. And like I say, once it arrives to the AV node, there's a very small, very short pause that allows for blood, the last amount of blood, to refill the ventricles, allows atrial kick to push in the last percentage of blood into it, so that, you know, the ventricles are, so the preload is higher in the ventricles and is able to pump more blood. Once the signal reaches the atrioventricular node, it comes down to the bundle of His, and then to the left and right bundle branches, and up to the Purkinje fibers, which depolarize your ventricles from both sides. Now let's switch back to pencil. There it goes. So next, what we're going to talk about is we are going to start talking about some electrocardiography basics. So electrocardiography, there's two electrodes, okay? So the positive and negative. electricity travels from negative to positive. So electricity travels from negative into positive. Okay, and this is called a vector. A vector is simply a word used to denote the direction in which the current flows. So vector is the direction of flow. Direction of electrical flow, actually. Electrical flow. There. Okay, so once we have electricity going from minor to plus, from negative to positive, right? Electricity coming this way, it's going to be a positive deflection. This in the ECGs. Okay, once we have the other way around, when electricity flows from positive into negative, we're going to have a negative reflection on the ECGs. So if current travels perpendicular, not parallel, so remember this is parallel, right? And this is perpendicular, right? So when current travels perpendicular, we can get either a biphasic or a flat line. So what it means is that because it's going slightly different directions, right? So we can either get a biphasic type of line like this, either up or down, because to accommodate, or both of them can just cancel each other out and just be a flat. Okay, next we're going to talk about Mr. Einthoven's triangle. This is named after William Einthoven, which is the man who discovered electrocardiography. And it's called Einthoven's triangle because it connects 3 points, okay? So the general direction of the vector, remember vector is the direction of electricity flow. So the direction of the vector is usually top down, top to down, oops, and is right to left. So what does that look like? It looks like this, right? Top, down, right to left of the heart. And it will make sense because if we start looking at the heart, at the anatomy of the heart, we can see that the SA node is very up high on the top right part of the heart. And once the electricity travels down throughout the heart, throughout all the path that we explained, it ends up being on the lower left side of the heart, right? So this is a vector in which the electricity follows normally in the heart. So we have 3 leads, okay? So what we're gonna do is we're gonna use a different color. So you can see the right hand and the left hand is connected to the left foot. So how it is this is a triangle. Right hand to the left hand, this is gonna be lead 1. Okay? And electricity travels this way. Lead 2 is gonna connect your right hand to your left foot. And that's the electricity, that's the way that the electricity is going to travel. Okay, lead 2. Lead 3 is going to connect the left hand to the left foot. Okay, so what this means is that for lead 1, if lead 1 is positive, if lead 1 has a positive deflection like this, we know the electricity is flowing the way it's supposed to flow, right? It's flowing from right hand to the left hand. But it's actually a little bit perpendicular, so we should not see a substantial spike in there. Lead 2, as you can see, is connecting the right hand to the left foot. And this one here, the electricity travels from the right hand to the left foot. And as you can see, it mimics very, very closely the vector of the heart, right? So that's why lead 2 is the preferred lead when you can monitor a patient. So you have a patient on telemetry, and you only have one lead that you want to monitor them in, lead 2 be the better lead to monitor them because of how the vector of electricity flows down. Lead 3 on this side, let me put here lead 3. Lead 3 connects the left hand to the left foot. So when lead 3 it's slightly more positive, we know that it's flowing through the correct way because it's still going down, right? Remember, like this. This is our vector, right? Down and to the left. So lead 3 is still going down, but it's slightly going the opposite way. So, but still it's going down. So it should, the positive deflection should be greater than the negative deflection. However, what would indicate if lead 1 was negative? If lead 1 was negative or negative deflection, we know that the current is flowing backwards. Same as lead 2. If lead 2 is negative, then we can say that the electricity is flowing backwards from the left foot to the right hand instead of the other way around. And the same thing applies for lead 3. So they are frontal leads and they're horizontal plane leads, okay? So the frontal leads, there are the bipolar leads and there's also the augmented lead. So we're gonna put here bipolar, which means it has plus and minus. That's all it means. Bipolar and the augmented leads. And the augmented leads, they're denoted by a small a. Okay, so the bipolar leads, this one, they go between two limbs. So which ones are the bipolar leads? Well, these are lead 1, lead 2, and lead 3. Because from the previous slide, let's go back, as you can see, it's actually connecting 2 points. That's what makes it a triangle, right? So they're bipolar in that sense, because they connect 2 limbs. Lead 1, like we said, it's actually going from the right arm. So right arm is negative. So right here, right arm is negative. And it's going to the left arm, which is positive. Right? Remember, electricity flows from minus to plus. Lead 2, we have right arm, which is negative, and is flowing to the left foot, which is positive. And lead 3, we have left arm, which is negative, right? And electricity flows to the left foot, which is positive. So we remember all the rules about the vectors and also how electricity flows from negative to positive in a normal fashion, right? Because if it flows backwards, then it's abnormal, right? And we can see that in the ECG. So based on this part over here, we can see that, you know, the lead 1 right arm connects to the left arm, and we can refer back to the Einthoven's triangle, right? Right arm to the left arm. So this guy has to be negative and this one has to be positive for electricity to flow like lead 1 is supposed to flow. Same idea for this one. Lead 2 goes from the right arm to the left foot. So right arm has to be negative and goes down to the left foot, which is positive, right? Electricity flows from minus to plus. And same idea applies for lead 3. Negative left arm, positive left foot. So the augmented leads, these ones are perpendicular to the bipolar, okay? Perpendicular. So that means they run like this, in a 90-degree angle. Okay, they're perpendicular. So what they do is, if you start thinking about it, so because we have 3 bipolar leads, we have 3 augmented leads, okay? And how these things work is, I'm going to go back to this over here and it would be a little bit better to explain. Actually, I'm just going to rewrite the triangle. So I'm going to redraw the triangle here, okay? I'm gonna redraw Einthoven triangle. So this is lead 1, this is lead 2, and this is lead 3. All right, and remember the flow of this. Right, so this is the right arm, this is the left arm, this is the left foot, just for reference. So what are the augmented leads? Augmented leads, because they run perpendicular to them, that means they run 90 degrees. So what would be the perpendicular lead to lead 1 right here? The perpendicular lead to lead 1, right, will be something like this. Does that make sense? It's perpendicular, right? This is lead 1 is running this way, and this is perpendicular. So which ones are the, well, how will we call this? Because it's going to the foot, we can put it A, V, F, right? And the way I remember is usually F for foot, right? So A, V, F. So A, V, F is the perpendicular lead that goes down and looks, you know, it looks down on the inferior part of the heart, right? If you look at it like this. So what the next one, what would be the perpendicular lead for lead 2? Because lead 2 is running down like this. What would be perpendicular? Would be something like this, correct? So this one, because it's looking at the left side here, left, we're gonna call it AVL for L, right, for left. And what this part does is it's actually looking towards the lateral side of the heart, and we'll explain that a little bit later. Last but not least, lead 3 goes down like that, correct? So what would be the perpendicular lead to lead 3? Good. It should be pointing towards the right, right? It should be like this. So be A, V, R for right. Now, if you start looking about all these leads and remember our vector, it's like this. AVR should always be negative, okay? And can you think about why? Because look at it, it's going actually all the way against the vector. It's going like that. So if positive is like this, it's flowing this way, it's positive, this is very negative if it's flowing back like that. So that's why AVR is always negative. Okay? Now that we got that, we have the horizontal plane leads. And these ones are also called the precordial, which means the chest. And these ones are the leads from V1 to V6. Okay? We should explain that a little bit further. So we're gonna put it all together using the axis circle, okay? So let's just rewrite some of the stuff we have, and we should color code it so that it's a little better to understand. So we're gonna put bipolar leads in red, okay? So bipolar leads should be red. And remember, these ones are lead 1, lead 2, and lead 3 because they connect limbs together and form the triangle, right? Now we are going to put the augmented leads. We're going to use blue, okay? And the augmented leads, remember, which corners of the triangle do they point? Well, we have A, V, R, because one of them points towards the right hand. We have A, V, L, because one points towards the left hand. And we have A, V, F, because one points towards the floor or points towards the foot, right? So that's one way to remember that. And again, we're going to remember the vector of how electricity flows, right? Top, down, right to left. Okay, so what is the axis circle? So the axis circle is exactly this part here but we're gonna redraw it in a nicer way, okay, so that we all understand. Instead of a triangle, I want you to picture it just the direction in which the lines go, and we're gonna make sure we pass all the lines through a one single point. Okay, so we're gonna pass all the lines. We're gonna put a pink dot here in the middle. All right, so that should be the line that every line should pass through. Now let's start with the bipolar leads. Remember, lead 1, right? How does lead 1 travel? Lead 1 travels from the right hand to the left hand, and it travels like this, correct? And remember, electricity flows from minus to plus. So this is minus to plus. Okay, lead 1. I'm gonna put here lead 1. Everybody good so far? Same thing, okay? Instead of drawing a whole triangle like we did before, we are going to put them all, make sure it crosses through the pink dot there. Lead 2, remember how it crosses? Lead 2 crosses down like this, remember? That forms that part of the triangle on that side. So lead 2, we can say that it passes down like this, because we wanted to pass it through the point, correct? So we can have here, this is negative and this is positive. Remember, electricity flows from negative to positive, and this is lead 2. Lead 3 was meant to be this part of the triangle over there, right? If it was in a triangle form, but it's not. So we're gonna pass lead 3 through the pink dot. So lead 3 will pass like this, correct? Minus, plus. This is lead 3. All right, so we're able to plot all our bipolar leads, lead 1, lead 2, and lead 3. Now let's plot our augmented leads. So AVR, start with AVR. Remember which side AVR was looking at? AVR was looking up towards the right hand, right? So if we start looking at it like this, and lead AVR is perpendicular to lead 3. Remember, look at here in the part I circle. Lead 3, because it's coming down from the left arm to the left foot. Then something perpendicular to that. You see the arrow pointing towards here. So that's perpendicular to this. Correct? Good. So now we can plot that. So lead 3 perpendicular will be like this. Correct? This is perpendicular to lead 3. So what we do is we'll just run this over like this. So this one here, because it's going the opposite direction, this one is minus here, and this is plus here. And this is AVR, right? Now, remember that I told you that AVR is negative? Well, because it's going against the vector direction, right? Okay, we have AVR. AVL. AVL was pointing towards the left hand. So, which lead was it perpendicular to? Well, it was perpendicular to lead 2, right? Lead 2 over here goes like this. Perpendicular goes like that. So it's pointing towards the left hand. So that means that AVL goes like this, right? Because if we start thinking about it, this is perpendicular to lead 2 over here. It's 90 degrees to that. So we have negative here, positive here, and this is AVL. Last but not least, the last augmented lead is AVF, or AV floor, or AV foot, the way that is easy to remember. And that lead is pointing towards the foot. And which lead is that perpendicular to? It's perpendicular to lead 1, right? Goes down like this. So this is negative, this is positive. And we have AVF, right? I want you to remember this because we'll see it again, and when we need to find the axis. When we start going through 12 leads, it would be important to use this to find which axis the 12th lead is leaning towards, okay? So next we're gonna put it together. So this is just an exact copy of this thing here. All right. The pink I just draw in there just to symbolize the heart. Okay. So we are going to put it all together. Remember the 3 coronary arteries of the heart, right? We have a coronary artery on the right side, the right coronary artery. We have the circumflex artery, and we have the left anterior descending arteries, right? So now let's look at this part a little bit closer and see what it all means. So we have in the ECG, we have portions for 3 sections of the heart. Technically 4, but we're going to merge one of them together, okay? So what I'm going to do is I'm going to use pink, and we're going to put the inferior leads, okay? So we have L, and let's put it here. So there is inferior. So there are inferior leads. We're going to use black for the anterior septal or anteroseptal leads, and we are going to use blue for the lateral leads. All right, everybody following so far? Okay, so this is the part that everything comes together nicely. Inferior, which part of the heart that I drew here, the pink heart in the diagram, which leads look inferiorly? Well, this is superior, right? Because superior means top, inferior means bottom. Medial means towards the midline, and lateral means away from the midline, right? So we just put that out there so that we know where our planes of references are. So inferior leads, which leads are pointing to the bottom of the heart? Inferior part of the leads. Well, we have lead number 2, right? Is pointing towards the inferior part of the heart. AVF is also pointing towards the inferior part of the heart. And we have lead 3. It's also pointing towards the inferior part of the heart. So therefore, which ones are your inferior leads? Well, you guessed it. Lead 2, lead 3, and AVF. Simple, huh? Now, we are going to skip anteroseptal leads for now, and we're going to jump to the lateral, and we'll come back to that. Okay? So lateral leads. Which leads look at the heart on the lateral side? Well, based on this, we can say that AVL looks at the lateral side of the heart, right? And lead 1 also looks at the lateral side of the heart. So lateral leads, we have lead 1 and AVL, right? AVR here, it doesn't do anything. So that's one of the leads that we can completely ignore. And because it's negative, it doesn't want to be the same as the others, then we can just ignore it. All right? Now, we're going to go through the anteroseptal leads. Remember this part over here, when we talked about the horizontal planes, the precordial leads, V1 to V6, well, we are going to plot V1 and V6 onto it. And because they're horizontal plane, they look at the heart not from a top-down perspective, but more from like a left-right or right-left perspective. So it's like a different plane, right? It's horizontal. So what we can do is V1 and V6. V1, we over here. Okay, going to put V2 over here, V3, V4, V5, and V6. Okay, so I think let me just redraw that because it might be a little bit better. So what we're gonna do is we are going to pull out this part here, and we are going to put it like this. Okay, so this is the real way it was supposed to be. Imagine that this little thing is actually outside of the heart. Well, why don't we put outside? So we're going to put it outside like this, all right? This one is a different plane of view. It's not looking from top down, but it's looking like this, side to side, okay? So, V1, you want to put it over here. V1. V2 is over here. V3, V4, V5, and V6. Oh, this drawing is more challenging. Sorry about that. Let's try that again. So V1, V2, V3, V4, V5, and V6. Apologize for the drawing. So as we can see, V1, 2, 3, 4, 5, and 6, they look at the heart from the anterior part, right? It looks at it from that plane of view, like this. It does not look at it up and down. So V1 is actually looking at the heart like this. If you can just switch your mind, and instead of pretending that these arrows are looking up, we're looking from the front into the heart. We're looking from the front. So that's why V1, 2, 3, and 4, because it's looking at the heart in that plane of view from left to right, is looking at it into the heart. What it means, these ones are your anterior leads, V1 to V4. Okay? So now you may ask, Carlos, so what about V5 and V6? Well, V5 and V6, if you start looking at it, it starts looking at the heart from that plane, almost from the lateral side, right? So those ones are also your lateral leads, V5 and V6. Does that make sense? So that's why we can see inferior leads, lead 2, 3, and AVF, because that's where these leads are looking down, right? Lead 2 over here is looking down this way. AVF is looking down this way. Lead 3 is looking down this way, and this is the inferior part of the heart, right? Your lateral leads, you have lead 1, which is looking at this way. This is the lateral side of the heart, right? So lead 1 is looking at this way. Lead AVL is looking at this way. And then we have V6 and V5, which are also looking at this way. So if you start thinking about it, this is all the lateral part of the heart, okay? Because V6 can be looking at it like this. So that's why lead 1 over here, lead AVL, lead 5, V5, and V6 are your lateral leads. And your anteroseptal leads are V1 to V4, because these ones are looking at the heart from the anterior part, right? It's looking at it in the three-dimensional way. These arrows are not meant to be pointing up, they're meant to be pointing towards the heart. So we're looking at it from the anterior part, from front to back, right? Perfect. So now just to put it all together. So we know that our inferior leads are lead 2, 3, and AVF, right? So inferior part, which artery supplies the inferior part of the heart? So the inferior part of the heart is supplied by the right coronary artery, correct? We discussed this earlier on. Lead V1 to V4 are the anteroseptal leads. These are the leads that look at the septum of the heart and also look at the anterior part of the heart. And which coronary artery supplies the anterior part of the heart? Well, that was the left anterior descending artery, right? And which coronary artery supplies the lateral part of the heart? The lateral part of the heart is supplied by the circumflex artery. And these ones are denoted by the lateral leads, V5, V6, lead 1, and AVL, right? So now you can start seeing that when you do see changes in different leads in your ECG, you can trace it back to which coronary artery it is affected. And that will gear your treatment towards patients who come in complaining of chest pain, shortness of breath, cardiac symptoms. You do an ECG and you do see things in different leads, then it will trace you back to whatever coronary artery those leads represent. So what I'm going to do is I'm going to wrap it up right here. Thank you for watching. I hope that this was a good review for nursing students, new grads, or even staff alike. In our next video, we shall continue with the coronary care series. And if you like this video, give it a like, subscribe, and I'll see you next time. Thanks for watching.